So now we can start.
We are starting our meeting today. We are the collaboration session of World Endoscopic Spine Foundation with ASSI, that is the Association of Spine Surgeons of India. I welcome you all. And I ask Dr. Sameh Al Hassan Morsi to give a brief introduction about World Federation of Spine Endoscopy before we start this meeting. Dr. Sameh, can you come on, please? Dr. Sameh.
Thank you, dear brother. Yes, I'm here. Do you hear me?
I can hear you. Sameh, we can see you and hear you. Can you please start?
Okay. Do you see my slides?
Yes, we see your slide.
Thank you. Good day for every one of you. I am Dr. Sameh Elmorsy from Egypt, President of World Federation of Spine Endoscopy. World Federation of Spine Endoscopy is the biggest international organization for spine endoscopy worldwide. I am the only founder for this association with great advisor, Dr. Malcolm Pestonji. If you don't know about it, please Google it. And we have so far 10 international courses, including cadaveric dissection and 4 annual congresses. Last one was in June 2022. And we have more than 120 international faculty joined us in last Congress. It was endorsed by multiple international organizations of neurosurgery and spine endoscopy, more than 14. It was also joined by more than 30 countries. More than 300 delegates have joined us in our past Congress. And we have endorsed many international courses worldwide. In coming January and February, we have ESICON and endoscopic spine workshop in Pakistan and in Turkey. And I'd like to ask you to join our 5th World Federation of Spine Endoscopy in coming June from 6th to 8th June. 3 days of more than 200 lectures and 1 day of full cadaveric course. At the end, I'd like to thank my dear brother Malcolm Pestonji for starting association and collaboration with ASSI and being the best advisor ever. Thank you all.
Thank you. Thank you so much, sir. I think we will now start with our program. So may I please request Hyeun Kim from South Korea to start his talk.
Yes.
He is considered as a genius in his work with monoportal spine surgeries. He is the master who has seen the evolution of spine surgery from its primitive stages through the transforaminal stages to the monoportal stages. And it is our pleasure to hear. Professor Kim, can you please start?
Can you hear my sound?
Yes, sir, we can hear you and see you well.
Yeah, thank you so much. Thank you so much for, it is my great honor to give a talk in ASCON conference. And thank you, Dr. Malcolm Pestonji, to invite me. This time my topic is technical tips of uniportal endoscopic posterolateral transforaminal lumbar fusion. As there have two kind of endoscopic uniportal lumbar fusion technique of transcambin approach and posterolateral approach, and also previously we think about that the posterolateral approach maybe from inside out outside, but nowadays I'm doing the outside in approach. These two techniques have an advantage and disadvantage. Among them, the posterolateral approach. This approach has more advantage compared to the transcambing approach due to the sufficient decompression is possible, and also the indication is not limited, and all kind of degenerative diseases that need fusion can possibly apply this posterolateral approach. And also in this paper, you can see the technique of inside out and outside in approach. I used this Kim's point and drilling from the outside in to resect the inferior articular process, and also skin incision near always some lateral part of the upper pedicle and docking to the medial of the facet area. And also you can see this paper of the showing the safe delivery system of the cage stem in spite of the uniportal full endoscopic lumbar interval fusion, this Harrison cage glider. And also this paper talking that more easily a resection technique of inferior articular process from outside in Kim's point. And also this paper talking that using the sufficient endoplate denudation, the endoscopic lumbar interval fusion has more advantage of the higher fusion rate compared to the open transforaminal lumbar interval fusion. And there have a distinctive advantage of the endoscopic lumbar interval fusion due to the endoscopic interval fusion can more close approach to the chronic adhesive disc point. We can resect the sufficiently chronic adhesive disc point. And also another advantage can give the sufficient endoplate denudation. Because of these two distinctive advantages, the endoscopic lumbar interval fusion can take a more sufficient clinical result and radiological result compared to the open transforaminal lumbar interval fusion. Here you can see the safe delivery procedures of the Harrison cage glider. Firstly, docking like this way and rotate like this way, and there is a maker to protect the traversing and acting nerve root together. You can see here. And also nowadays, I use the 3D print cage to enhance the high fusion rate, and it already well known that the 3D printed cage have a higher fusion rate compared to the previous PIC cage and metal cage. And also you can see like these cases of L5S1 highly migrated cases and highly restricted cases, not in open surgery, but it need a sufficient reduction of this chitin, make a sufficient lumbar lordotic angle. Endoscopic lumbar interval fusion can possible due to sufficient chronic adhesive disc drilling, and also you can see this X-ray show the sufficient reduction of the high retrospondylosis cases. And also this paper talking, Dongchan Lee talking that in spite of the high fusion rate, L5S and L45 have some substance rate. Because of that, sometimes we can try the 2K insertion technique. Nowadays, it is very easily. And this post-operative skin incision of foreskin, I use the same skin incision of the pedicle screw incision. These operative procedures, firstly docking, and then expose the inferior articular process and the lateral facet area. And firstly seeking the Kim's point and drilling fastly, and then resect IAP easily. And then SAP also same method from lateral to medial, medial to lateral, and then can resect the SAP more easily. Then you can insert to the working channel to the foramen area then during this disc, chronic adhesive disc, you can see severe collapse disc more easily release the restoration of this height. And finally, endoplate denudation can make then enhance the higher fusion rate, and we can insert the 2 kg like this way. And the clinical result, you can see this paper, due to this advantage, we can take sufficient focal segmental correction, sufficient disc height restoration, sufficient spondylolisthesis reduction is very, very nice compared to the open spine surgery. And also this paper also talking that using this endoplate denudation and sufficient chronic adhesive disc drilling, we can make a high sufficient fusion rate, and you can, this case is only 1 year, make a sufficient fusion in spite of the endoscopic fusion. And also, recently we take another advantage due to the we can insert a large angle, the 3D print KG. You can, this paper talking that indirect decompression like this cases, and this case not decompression of the contralateral and ipsilateral together. Finally, you can see the spinal canal reduced, and contralateral foramen also indirect decompression is possible. This another advantage is that due to the characteristics of the radio frequency, and it makes some vegetative neuropathy ablation and paraspinal muscle relaxation. Due to we can make sufficient paraspinal muscle preservation, and sometimes paraspinal muscle recovery is possible. And also, I will see some of cases. You can see the high severe collapse spondylolisthesis cases. You can see 2 kg insertion, and after spinal alignment corrected very, very well. And also, you can see these cases. It looks like not easy, but with only this 2-level endoscopic lumbar interval fusion, you can see the spinal alignment corrected very, very well. And also, this case is lateral vibration and high-grade spondylolisthesis. Also, using endoscopic lumbar interval fusion, you can see the reduction is decompression, and reduction is very, very nice to this, like these cases. And also, these cases is failed back cases. And after limb implant and inserted KJ2 here, you can make sufficient alignment correction, and the patient very well clinical result in spite of the long-term follow-up. And also, this case is my final cases. Due to the endoscopic lumbar interval fusion has completely preserved the structures, or not only ligament, muscle, and facet, and all structures, and but also the can preserve the skin. We can give to the patient their spontaneous reduction chance. You can see this patient preoperatively. The patient have so severe pain more than 3 months due to chronic discitis, due to the patient needed 4-level fusion. And after operation, you can see the spinal alignment corrected, and 6 months, and 1 year, and 2 years, the spinal alignment corrected spontaneously, and the patient have no ASD problem. And also, due to this advantage, I believe that in the future we can possibly, no open surgery, no suture after operation, no dressing after operation, no transfusion during operation, no general anesthesia, and then minimizing the infection after operation. I opened my hospital 4 months ago. I performed about 100 cases fusion surgery, but still we have no open surgery, no suture, no dressing, no transfusion, no general anesthesia, and no infection. And I believe that now we endoscopic spine surgery developed so much, but still ongoing state. But I believe that some things changed abruptly, like endoscopic spine surgery. Believe that changed the world for degenerative spine, not only degenerative spine but also many spinal disease patients. Thank you for your kind attention.
Yes, sir. That was perfect. Amazing. Amazing work, sir. It is a privilege and honor to have you with us, sir. I will now request the next speaker, Dr. Park. And sir, I will, Dr. Kim, I request you to stay online because after the third talk, we have a discussion. So, Dr. Park,
See.
Yeah.
Park, start.
Hello, everyone. Can you hear me?
Yes, sir.
And can you see me? Can you see the presentation? My presentation?
Yes, sir.
Yeah, thank you so much. I'm delighted to be here today and I would like to express my gratitude to all the ASCON faculty for making this possible. I also would like to extend my special thanks for Professor Pestonji, our esteemed chair, for his invaluable contribution and support. Today, my topic is bipolar endoscopic surgery for the decompression of thoracic ossification of ligament problem. As we know, ossification ligament problem is one of the main causes of thoracic myelopathy and is more common, more frequent in the East Asia, Japan, Taiwan, and Korea. And typically, it is combined with lumbar spinal canal stenosis, especially over the 70%. And also very commonly combined with cervical canal spinal canal stenosis. So radiology, it is ossification ligament problem start from the capsular portion and extend from the capsular portion to the extend to the medial part like this. And also start from the posterior part to the move to the anterior part. And before operation, it is very helpful to know there are dural ossification. In the study of our hospital, also preoperative study, there are nearly 40% of dural ossification there. So for the decompression, bipolar endoscopic surgery is one of the best methods for the decompression surgery. So as we know, knee arthroscopic surgery move to the spine, just like this. And we can make water chamber on knee cavity with a press or water press like this. But on the spine canal is connected to cranium. So if you fail the control of outflow, the pressure of surgical field increased highly, and it can make some big problem in the cranial, delayed awakening, seizure-like activity, and other things. So for successful operation, I have many experience for decompression surgery over the OLF. So I would like to highly recommend, make your surgery stage, drilling stage, and the separation of ligament problem stage, and removal of ligament problem. So, and the other important thing is please make your pathology with joining. Joining is very, very important. Compression area is a high risk area. And the intermediate area is a normal ligament problem. And the safety area is medial wall, lateral to the medial pedicular wall line. So here is your safety area, and here is a dangerous area, and here is the intermediate area. If you perform your operation after making joint, it is very, very helpful, and your operation will be successful and without any damage or injury to the spinal cord. So drilling stage is most important. Drilling stage is most important. From the medial wall of pedicle to the make like drillings, medial wall of pedicle drillings, and isolation of separation of ligament flavum through Y-shaped separation. So external wall, your lateral drilling is superior articular process. Right lateral limitation is right superior articular process. Left lateral limitation is left superior articular process. Personally, I have 94 cases and about 120 levels of decompression of ossification ligament flavum with the biportal endoscopic systems. So I would like to talk about firstly removal. Here, yeah, this is when you drill the pedicle here, we can find the medial wall of pedicle like this, and we extend our drillings, remove drillings to the medial wall of pedicle line here, like just like this. This line is a shaped line, and separate your ligament flavum Y-shape like this, and the drilling like this. This is a surgical flow of my surgery. This skin post-op skin incision, and location for the skin incision is the most important. And I like to have a transverse skin incisions like this. And for the good outflow, I use a trocas. I told it again, with the water pressure, we can make water surgical field. Usually I start spirolaminar junction, drilling start laminar junctions, and expose the ligament flavum with the drills. I like, in the early stage of my operation, I use it to the side cutting drill bore, which has a self-suction hose. As we know, ligament flavum is just like a butterfly. So here is a exposure of head of butterfly. I'm drilling lateral end of here IAP. If you drill the IAP, you can find the SAP on contralateral side, and also exposure with drills exposure where this corner is also important. And I'm drilling here. And the separation of ligament flavum with the Y-shape. Y-shape separation of ligament flavum is very important. So this is the drilling stage. Let me, and then you can remove in the not severe case, mild case, we can remove the ligament flavum with just like 2 pieces. Right side ligament flavum remover, and the left side ligament flavum. This is the case for the mild case. After drilling, complete drilling, and then remove the ligament flavum. That is my talk today. After completing your drilling, and then please remove thickened ligament flavum. This is a case for the mild. I'm removing left side thickened ligament flavum. Well, we are worried about the water pressure during my surgery. When the outflow is the occlusion, if you open the outflow, the pressure of spinal cord is decreased here. So making outflow is the most important. This is a case for a more severe case. Actually, this patient has 2-level severe canal stenosis. Same, my message is the same. After drilling IAP and the exposure of SAP, and then removal of SAP on the safety angle. Here is the safe zone. Removal of SAP with the safe zone, and the removal. Only pull out, not pushing. Only pull out, take out, pull out, without compression of spinal cord. It's very important. Please don't insert your instrument in the compression area, dangerous area. Only please insert. We can insert the intermediate, no compression area. Here is a no compression area, so we can remove like this. So no compression of danger zone during the operation is the most important. This is the most severe case. There is no dura here, no dura here, no dura. Yeah, dura and ligament flammable is one piece, yeah, one component. But we can prevent the arachnoid membrane. It's very, very important. With the removal, we can remove the ossified ligament flavum with the dura, with the preservation of arachnoid membrane. So, and then we can patch it with the taco cell. It's a fibrin taco cell. We can patch like multiple layer like this. So we can remove the ossification with the dura, with the preservation of arachnoid membrane, and the sealing with the patch method. Fibrin silantin, with a fibrin silantin. This is a fibrin silantin. I will talk, this is a OLF with dura, is fused. But with water pressure, we can separate the OLF with the preservation of arachnoid membrane. And we can repair this method. This is a method my method for the most severe case. So this is post-op 2 months later after fibrin silantin. This is a fibrin silantin with the preservation of arachnoid membrane. This is a post-op cases. My case 2 levels decompression. Also 2 level myelopathy, but with a bipolar ULBD technique, drilling bones and the separation ligament flavum and the removal ligament flavum. Make stage and make zoning is very important. This is also postoperative CTs here and preoperative CTs and the 3D postoperative 3D CTs here. Today my talk is don't compress the dangerous area during your operation. Only pull out the pathology after drilling and separation of ligament flame. In the early stage, only one patient or one of my patients complained the postoperative weakness compared to preoperative, but other patients have some tolerable outcomes. And I'm very worried about the postoperative hematoma. So always I did immediate postoperative MRI when we have operation. At same day night, I checked the postoperative MRI to prevent the postoperative hematoma corrections. So my talk is please make your operation stage. Drilling stage is the most important. Drilling your bones, IAP and SAP, and separating your ligament from flavum and the safety area and the removal is the ligament from. Try to remove angular removal is the most important. That is my talk. Thank you so much.
Thank you so much, Professor Park. Amazing, fantastic analysis of the thoracic spine, and the zones of working was real application of mind. Fantastic talk, sir. So without wasting time, now I will go to Dr. Pornpavit to start with his talk, and after that we have a 7 minutes discussion session. We will be taking any questions and answers and then proceeding with the next session. Without wasting time, I request you to please start your talk, sir.
Yeah.
Thailand.
Good afternoon. Yeah, I cannot share my screen. Please let me share my screen.
Yeah, please share your screen, sir.
Yes.
Take your time, sir.
Okay. And first of all, I would like to say thank you for Malcolm to have me here, and hope you have the good time for the Merry Christmas and Happy New Year soon. Okay, I still cannot share. Please help me. Please allow me to share my screen.
Yes, sir. Please go ahead. Dr. Park, you will have to stop sharing your screen, sir.
Yeah. Sorry.
You'll have to stop sharing your screen. Yeah.
Are you okay?
Dr. Pornpavit, go ahead and now share your screen, sir.
Okay.
Yeah, we can see you, sir.
You,
Fantastic.
okay, you can see my screen right now. Thank you so much. First of all, I would like to say thank you again. And my topic today is alternative approaches for uniportal, endoscopic in foraminal and extraforaminal pathologies. And the new is not new, but it's modification for Wfse approach is the posterior oblique approach. And for example, this case is the foraminal disc and extraforaminal disc. And if you see on the coronal view, you can see they have two parts. One is the extraforaminal zone disc herniation, and another one is the foraminal zone disc herniation in the same case. So this is the conventional transforaminal approach. Normally, we perform under local anesthesia, but in some cases, the patient cannot tolerate the local injection. So they ask us to perform under general anesthesia. So we need to have the intraoperative nerve monitoring because of the cambium angle is quite narrow. And also the insert, the needle is the insert by fluoroscopy, but it's by as well. So we have many indications for the transforaminal approach in the past, particularly the L5S1 HNP with the highlighting iliac case is very difficult situation for the transforaminal approach. So we have to do the outside in technique. So let's see the conventional technique. We approaching to the superior border of the lower pedicle because this area is far away from the nerve root, and then we put the dilator in and we put the endoscope. Then we can approaching to the foraminal zone. Okay, according to the Kang-taek Lim, he proposed the paramedial approach. Is the same purpose to approach to the foraminal area. And his technique is a little bit oblique, but the core of this technique is docking to the isthmus. Okay, let you see the isthmus. The isthmus have the reticular artery, and beneath the pars is the nerve root. So if you use this approach, you have to be careful because you may be injured to the reticular artery, and if you're drilling the pars, keep in mind beneath the pars is the nerve root, like this. And my suggestion is the posterior oblique lateral approach. So this purpose is to perform under general anesthesia because some patient cannot tolerate the local injection. But without the intraoperative nerve monitoring, because it's a cost. Okay, and let's say this is the paramedial approach, the docking in the isthmus, but my approach is docking on the lateral part of the SAP. Or in some case, we docking to the TP, the transverse process. Is quite easy. Look at this. We docking, this is a paramedial, right, on the isthmus, and then go up and then identify the nerve root. My suggestion is docking the SAP and go down to the TP and along the pedicle to the disc. Or the alternative is dock on the TP, and then you along the pedicle go to the disc base. It's quite safe because it's away from the nerve root. And some cases you can drill the SAP to whitening the foramen, and also you can drill the pars to entrance the interspinal canal. Let I show the little bit technique. You can see I tilt the C-arm oblique around 70 degrees, and I dock my dilator to the SAP, something like that. And then I palpate the isthmus and then palpate SAP and TP. Okay, now we push the dilator to the TP, and then in the case, you can see in this case, they have the up migration fragment, they have the foraminal fragment, and also they have the extraforaminal fragment as well. So which approach is good for this case? If you look at you can see they have three parts of this fragment in three. You see, if you use the interlaminar approach, you can remove this interspinal canal, but very difficult to remove the foraminals. But difficult. But extraforaminal is quite difficult for interlaminar approach. But if you perform transforaminal approach, also difficult to remove the up migration the fragment. So I suggest you to oblique lateral approach, dock to the SAP or pass or transverse process, and then you remove the SAP, and then you can decompression the foramen, remove this fragment in the foramen and extraforaminal, and then you remove some part of the isthmus approaching to the up migration fragment and remove it. Okay, I set up the C-arm allow 20 degrees to identify the facet, and you can see, you can identify the Scotty dog on the C-arm, and then put your dilator into the SAP, and then follow through the pedicle, and you can identify the medial bounds of the dorsal lemma, and I recommend you to make the lysotomy in this step, something like that, and then follow the pedicle, and then you can approach to the foramen, and you can approach to both traversing nerve root and exiting nerve root in the same approaching. You can see we can achieve the very good area for the endolip as well. Okay, I would like to show you the short video to show, to summarize the step. Like this case is the application as well. We perform posterior approach. In some cases, the SAP quite large, so we have to remove some parts of the SAP first, and then now we can approach to the transverse process, right? This is the transverse process. You can identify the medial bounds of the dorsal lemma. I recommend to make the lysotomy by cut the nerve. And also you can use this approach to make the lysotomy as well. Okay, after that, you cut some parts of the transverse process, go down to the foramen, and then you can identify the interforaminal ligament, remove the ligament, and immediately you can identify this intervertebral disc. And you go up, you can see the exiting nerve root. If you go medially, you have to remove some part of the medial border of the pedicle. And then remove some parts of the part in the case of you want to go to remove the up migration, this fragment. And remove the lateral ligamentum flavum. Okay, and then go through medially, remove the lateral flavum. Then you can identify the traversing nerve root in this area. After you remove the medial parts of the flavum, that traversing the nerve root, and go a little bit upward, and this is the axilla area. You can see this extrusion. Then this is the application disc fragment, and you confirm by the C-arm interbody, and then you can remove the application disc without dealing the pedicle, only the remove some parts of the pars in the articularis. And this is the disc fragment. Okay, this fragment removed, and we stop the bleeding to check. No, this fragment remain in the entire spinal canal. Okay, we go laterally and see this is a foraminal disc fragment, right? And then we can remove the lateral disc fragment by the same approach. Okay, this approach also good for the endolip as well. So I don't want to talk about the indication. For this is the K-lip, right? We go to the tan cabin. It's very narrow area. And if you perform the tan facet T-lip, your placement of the case is not in the good position, not medially enough. And my suggestion is the posterolateral lateral approach. And you can see I put the pedicle screw first, and I put the case later, because I got two cases that I decompression first, and I put the screw after I have the pedicle crack and fracture. So I avoid this by put the pedicle screw first. And this is our technique, something like that. Okay. And also I use the Harrison tube to perform this surgery. Thank you for Harrison. And you can see and also we can perform the contralateral decompression as well in this approach. So in conclusion, we have the good candidate for many indication, and also the advantage is not the by technique. We can access to the foramen maybe safer and have more room to entry than go to the cabin triangle. And I hope this technique maybe you can extend to the spinal canal as well. Thank you for your attention.
Thank you so much. What a wonderful talk, sir. What a wonderful talk.
Thank you.
A lot of surgery similar to you in using UB to remove up migrated fragments. And
yeah.
Those up on Facebook also. So I was thinking across the continents, they seem to be fantastic. Thank you. I really enjoyed your talk. We have some, if there are any questions from the audience, we are welcome to take them. Otherwise, I have a couple of questions. One question is to Dr. Kim. Dr. Kim, I really appreciated, actually it's not a question, it's an appreciation, that you have adapted rather than a vertical approach, an oblique approach, and that you have opened up the facet joint from within, expanding inside and then outside. That really opens up the entire area of the Camben's triangle for me. And it will help you to, my understanding is that it helps you to take care of a lot of other associated pathologies and gives you a very safe and a corridor going into the center of the disc. So I think that adaptation by you is a very fantastic adaptation, Dr. Kim. This was my observation of your talk, and I really appreciated that. Mm-hmm. Dr. Park, I had a small question for you. In your patients with very severe, have you had a significant improvement in spasticity? I believe the pain goes away, the VAS score improves, but the spasticity does not improve in my series of patients. So I wanted to know your opinion regarding your patients.
Yeah, actually, most of my patients has not severe symptoms. Unfortunately, I don't have experience for spastic treatment. Okay. Most of my patient is weakness, subjective weakness, and so yeah. So I don't have the experience for treating spastic. Sorry for that.
Okay, okay, sir. Thank you, sir. That is just wanted to know that. Dr. Pornpavit, I have now no question for you. I don't think the audience has put up any questions, so we can go ahead with our next session. I would like to thank Dr. Yumjinwa. I think he has joined us. Dr. Yumjinwa, are you there with us? Can you please put on your speaker, sir? Unmute yourself. And can we have you share the screen, sir?
Can you hear me?
Yes, Dr. Yumjinwa. Welcome, sir.
Oh, okay. Nice to meet you. Okay. Looks very well. Looks good. Okay. Okay. So, can you roll?
Yes, we can.
Yeah. Okay. Can you see my slide?
Yes, sir. We can see this.
Okay. Can I start?
Please do, sir.
Thank you. Nice to meet you, everybody. Hello, everybody. My name is Jinaum. Now I'm working in Al-Khaliji Hospital in UAE. Yeah. Thank you for, especially thank you for Dr. Malcolm and giving me this nice chance. Okay. Okay. Today, my topic is current state of bipolar endoscopic spine surgery. This is my disclosure. Okay. Seeing is believing. Yeah. And already you know, the biportal endoscopic principle is the same as knee and shoulder surgery. But difference is there is no working space in the spine. That's the problem. Yeah, you know, the Argentina doctor, D. Anthony, first, this technique introduced this word, 1996. And this is original article. And at that time, they did surgery, lateral position. And fortunately, I have a chance to meet and chance to know Dr. Abdul Ghaffar 2001, and he's my teacher. And after then, I and my student, Dr. Son, changed it and established. We applied radio frequency device and we changed it from position and we make some instrument. There is a big establishment and development in Korea. So during 10 years, there are big change. So I dare say there is learning curve. Level 1 is herniated disc. Level 2 is unilateral laminotomy of bilateral decompression and revision surgery. Level 3, endoscopic dural repair and foraminal decompression and cervical discectomy, thoracic decompression and contralateral approach and endoscopic fusion. And level 4, extreme TLIF surgery and cervical lateral mass screw fixation. And future, we don't know yet. But this is my personal opinion. And I show the cases. Herniated disc cases, the procedure is, as you know, as you see, the same as open surgery, minimally invasive microsurgery. We have to do laminotomy and phlebectomy, and we can see the ruptured disc, and we can remove the ruptured disc fragment. But as you see, the surgical view is very different. So can you see this kind of picture in the microscopic surgery? I don't think so. In the microscopic surgery, we have to control breathing and we have to retract more. But in endoscopic surgery, we don't need retraction, and we can see the root and around the root area and ruptured pathologic disc clearly. That's the big difference. So that's the reason seeing is believing. If you don't agree, but I believe seeing is believing. Okay? And next case is next level is I dare say L4-5 stenosis, because about 10 or 15 years before, when we first started doing endoscopic surgery, at that time, only in the world, there is only one portal endoscope. There is no biportal endoscope introduced. At that time, with endoscopic surgery, we cannot solve the stenosis problems at that time. Only we can solve disc rupture, the disc problem only with the one portal endoscope. So there was a challenge. But 10 years before, we tried to do decompress the stenosis problems. So we applied the concept of unilateral laminotomy and bilateral decompression surgery. So now it is very easy to solve the stenosis problem with biportal endoscopic surgery. So we can remove hypertrophied ligament problem, and we can decompress the bony stenosis department. No problem. We can use any kind of drill on calcium lungers, no problems. There is a big difference, and we can use any kind of instrument. Okay, and also the surgical view is beautiful. We can see the contralateral part without any disturbance. Also, breathing control problem, and with under the normal cell line situation, we can see the root and pathology department without serious bleeding. There is a big difference. So I and Dr. Ho and Sang-Gyu Son published this article. And next level, I think level 3 is herniated disc problem, herniated cervical disc problem. Especially in this MRI, we can observe right side, this is right side C67 herniated disc problem, okay? In this case, what is your gold standard approach? Do you recommend, if this patient is your family member, do you recommend ACDF or posterior endoscopic approach? If your family member, your daughter or your mother, how can you recommend ACDF? I don't recommend. I think the first choice of surgery, this kind of patient should be first choice of operation should be changed to endoscopic decompression, right? We have to change it.
Yes.
Oh, okay. So C67 right side approach. So a little different, but at first time I have to remove the laminotomy and the foraminal. But the surgical view is very clear, and we can see the cervical nerve very clearly. And one portal endoscopic surgery and biportal endoscopic surgery is a little different. With one portal endoscopic surgery, we can do this kind of dissectomy, we can do it, but instrument handling is not easy, it's not free. So sometimes we can remove the ruptured fragment with one portal endoscope, but one portal endoscopic surgeons does not agree with my opinion. Sorry about that, but you can do it, but sorry, but so you can see, so we can remove the ruptured disc fragment, and we can manipulate cervical nerve without the root damage. And also surgical view is very beautiful. Okay, we can move the cervical nerve, no problem, but don't retract cervical nerve too much. We have to be very careful, and you can use the hook, explore around the cervical nerve. If there is a remnant disc is there, you can remove, no problem. There is a big difference, I think, with one portal and biportal endoscopic surgery. And level 3 also, we try to do fusion surgery under endoscopic surgery. So principle and procedure is the same as TLIP surgery. So you can do laminotomy and discectomy and decompressive foraminectomy and prostatectomy, and we can put a cage into the intradiscal space without serious nerve root damage. But there is problem, because this procedure should be done under normal cell line. So we worried about it at that time, okay? But there is no serious complications. And now we can use a dual portal endoscope, a dual portal expandable cage, a dual expandable cages, 3D cages under dual portal endoscope. In America, they developed expandable cage And I used this in this area, and it's very nice, but a little expensive. So that's the problem. But there is, it is a very nice cage anyway, but price is very, very high. So that's the problem. So Dr. Ho and Dr. Son and I published this article, fully endoscopic lumbar fusion. There's no serious problems under endoscopic control. So next level, I think we can use a large only cage through the endoscopic control. This post-preoperative post-MRI, we can use a large cage. We can put a large cage into the L4-5, L5S level. So this is L4-5 level. Procedure same as TLIP surgery, but we have to remove the facet joint totally. That's the difference. So because we have to expose the Cambridge triangle totally, we have to see the exiting and transversing nerve root clearly. So this is exposed Cambridge triangle. You can see the transversing and exiting the root clearly. And discectomy, but we can use the ordinary spine instrument without any problems. So retraction the transverse nerve root medially, and we can try trial in 45, and venous is 18. And we can put a large only cage under the endoscopic control without nerve root damage. And 45, 15, and 6-degree lordotic only cage. And we have to do transverse and anterior line of cage. I call it posterior orthogonal maneuver. So we can put a large cage, line anterior and transversely. Also, L5SN level, there is no problem. Fortunately, L5SN level, if we remove the facet joint totally, we can get enough space bigger than the 18 or 20 or sometimes 21. That means we can use a large only cage without nerve root damage. So you can see the exiting nerve root, and you can use Kelson lungers, and you can use a shaver and all kind of open surgery instrument without any limitation. Also, you can use large curette for end preparation. But about the end preparation problems, we have to discuss later. And we can put a large cage. This is the venous is 18. So without nerve root damage, L5S1 level, very safely we can use a large only cage. But sometimes we have some difficulty to moving the cage, line the cage anterior and posterior line, anterior transverse line. Sometimes we have problem. So this is post-operative X-ray. Looks nice. So Dr. Ho and I published this article 2021. And level 4 will be cervical lateral muscular fixation. It's not easy. It takes a long time. We have to develop some nice instrument for this procedure, but it takes the operation time is too long time. I don't recommend it right now. So we have to think, we have to review the pros of endoscopic spine surgery. Already you know, we can get a nice enhanced visualization, no need retraction, and also less soft tissue damage. And we can do possible complete decompression around the nerve root. And especially for the obese patient, we have very good, nice advantages. And we can do possible with under local anesthesia. And endoscopic surgery is one of the factor of our ERAS. So obesity is pandemic, okay? So we can do endoscope surgery under obese, no problems with the obese patient. But we have some problems. So there is no working space. We have to make a working space. It's not easy. It looks easy, but not easy. Also, water-based surgery and multiple levels we can do it, but it takes time. I don't recommend. So there is a learning curve. We have to be very careful. So this is my personal comparison. Surgical view is between, surgical view is very nice, I think, okay? Microsurgery compared to microsurgery and PLD. So about the instrument handling, okay, very nice, I think. Learning curve is between the microsurgery and the one-portal endoscopic surgery. Also, we can do fusion surgery under endoscopic control. But there is a significant individual learning curve and mid to long-term investment we have to do. So challenges. Triangulation is not easy, especially for neurosurgeon. Okay? So creating artificial working space also is not easy. So we have to make a good working portal, and we need proper water passage. So my concerns of biportal endoscopic surgery. Also, I had a dural injury at the learning curve stages. I have, okay? So be careful. Also, we have to think about intraspinal pressure problems. So also, I don't recommend overuse of endoscopic surgery. We can do it, but we cannot solve all the spinal problem with endoscopic surgery. So I don't recommend tumor surgery. Some Korean surgeons, endoscopic surgeons, doing surgery, intrathecal, extramedullary tumor, but I don't recommend. We can do it, but it's dangerous. So I don't recommend also deformity correction surgery. We can do it, but it takes a long time. Let them do it. Okay? Also, compressive revision surgery. Sometimes I don't recommend, but we can do it. Okay, so future of UV technique is not limit. The surgeon is the limit. So we can collaborate in navigation and robotic surgery. So biportal endoscopic spine surgery would be promising MISS. Thank you for your attention. Thank you.
Amazing talk,
Thank
sir.
you. Yeah.
You've taken us through the world of UB.
Yeah.
Beautifully put in a nutshell.
Thank you. Thank you.
Speaker, Dr. Hayati, now to please share his screen. Sir, can you stop sharing your screen, sir? Dr. Yumjinma, thank you so much. Wonderful talk. Amazing.
Thank you so much.
It's nice.
Okay.
Dr. Hayati, can you start your talk, please? Screen, brother.
Sharing my see my presentation. Do you see my presentation?
Yeah, we can see you, sir, and we can see here.
Okay, thank you very much. First of all, I want to thank again to Dr. Malcolm and Dr. Sameh for their good activity and their valuable invitation for me. And then I also want to thank the Dr. Hyeun Seung Kim, Dr. Park, and Dr. Malcolm Pestonji, and also Dr. Sameh, and all the other our faculty for their very valuable support for me in Turkey, Bursa, in February. We are exciting and waiting for your coming. Thank you again. Thank you very much. Yeah, I will talk about the complications of the UB. The previous speakers has very nice presentations, but they talk about the nice aspect of the UB. Then I will talk about the bad side of the UB and briefly in 10 minutes. Okay. Yes, you know, all surgical techniques, of course, have some complications. And the endoscopic surgery is promising in a very nice benefit from for the patients and the surgeons, but also they have very severe complications. The complications can be talked under the three main topics. And I tried to prepare this presentation based on the patients and some complicated cases, their feedbacks. So yeah, I can talk under the three main topics. I saw the complications that it can cause from the surgical technique, and it can cause some patient-related factors, and also it can cause from postoperative management. If you talk about the surgical technique-related complications, in surgery, most of these complications arising from the poor surgical technique, unfortunately. We can say that most of them is coming from the skill-based complications. The surgeon can make inappropriate surgical working space. Maybe they will they can miss the cornerstone during the surgery. And also maybe because of lack of enough experience, then some of the surgeons can recognize the endoscopic anatomy. And some of complications also coming from the lack of knowledge, wrong indication, wrong patient selection, and wrong technique selection. And others, I saw especially in some experienced surgeons, the over self-confidence can cause very devastating complications. So we have to be careful about this. I saw then many surgeons, they have over self-confidence. They have inappropriate and non-conforming procedures they're doing. They're trying some things on the patients, and also they have also excessive optimism, or they have some unrealistic. So the others have irresponsible. The manner is irresponsible. They don't care about the literature or the basic knowledge. They just looking at the short time results. Maybe they can obtain by using some medicine. So what is the solution? Yeah, we have to improve our surgical skills, of course. For this, the surgeon should follow the learning steps. The surgeon should learn about the cornerstone and check the location during the surgery, especially unexperienced surgeons. And we have to be familiar with endoscopic anatomy. The other, we have to choose our technique by using exceptional literature. You know, there are many papers in the literature you can see, but it's most of them maybe, unfortunately, is untrustable. For example, sometimes we refuse or we unaccept some the papers for example, in one journal, but then you can see this paper accepted as an accepted paper in another journal. So you have to choose the literature very carefully. Then we have to know the surgical indication is not enough for surgery in endoscopy. Yes, you can see, you have some indications for spine surgery, but we have to consider is it appropriate for endoscopic surgery or minimal invasive surgery or microsurgery or open surgery or etc. So And also we have obtained the enough technical and OR conditions for the successful surgery and without the complications. So also we have to know that all of techniques have some limitations. Always we have to care about the protecting innocent tissues, and also we have to protect patients, and also we have to assess our result after surgery, and also we have to consider about to obtain the mid-time or long-time results instead of the short-time results. When you ask the surgeon why you do this, they say that, but after surgery, the patient was patient-free, pain-free. It is not enough for us. So if we look at the complications related, instrument-related complications, we can see this. Most of complications during the surgery can cause the using the tool usage. For example, punching the neurogenic tissues is possible. Dural tear, nerve root injuries, neural injury because of some osteotomes, and radiofrequency-related complications can be seen. Direct radiofrequency exposure of the nerve roots or dura can cause the constant neurological impairment. And also excessive radiofrequency usage can be increase the fibrotic developments or the osteoporosis or some instabilities. And also the other very useful tool is high-speed tools or burrs. Arthroscopic burrs is very useful devices, but can be very dangerous, and the complication related with the high-speed burrs also, and also the arthroscopic burrs can be devastating. So we have to be careful about this. And the others, the traction complications can cause the transient or constant neurogenic impairment. So what is the solution? You should be gentle during the surgery. We have to be careful about using the Chairpersons punches, which is called the dural tear mostly. And we have to don't use some exceptional tools without enough experience. For example, some osteotomes can cause the nerve root injuries. We have to use lower energy after seeing the dura, the radiofrequency, and avoid from the direct radiofrequency exposure to neurogenic tissues. And we have to use appropriate size and shape of burrs. Also, we have to keep in mind about the Bernoulli's principle during the high-speed burrs or arthroscopic burrs, because the Bernoulli's principles can cause the dural tears or nerve root injury, even you closed the drainage hose of drill or handpiece. You have to be careful about this. And also, if possible, we have to use the burr. Also, the surgeon should avoid from excessive retraction of the nerve root and spinal cord. We have to obey the fluid management. So, the other complications can be talked under the topic, which is the hydrostatic pressure related complications. We can see some central nervous system complications, ophthalmic complications. We have two cases, headaches, dizziness, and etc. So the solution, we have to avoid from the excessive, so we have to obey the fluid management rules. We should keep the pressure about 30 to 50 millimeter mercury. We have to keep the head of staple up position at least 10 degrees. It can help to reduce the nervous, central nervous system pressure. And also we have to be careful existing ophthalmic or CNS pathologies like glaucoma or hydrocephalia. Now, this is the very hard case. You see the disc adhesed to dura very strictly. This case was the scoliosis case, and we did the decompression, but because of severe adhesions, now we have the dural tear, the anterior cord. If you have unacceptable dural tears like if this dural tear could be in the posterior aspect of the spinal cord, maybe we will do the revision surgery for this. But in anterior, we can put just taco seal is enough. And this case was 35 years old, male. After surgery, the patient said that I cannot see the under the half of my seeing area. We surprised. Then you see very severe retinal bleedings, both sides. But luckily, after 20 days, it became spontaneously. Now let's see the patient-related complications. If the patient has some comorbidities, of course, we have to be careful about the management of the surgery and after surgery period. And also, it can cause the skeletal system can cause or can increase the complications. And also, if the patient has some existing factors, for example, previous surgeries or job-related conditions, also we have to be careful about this. So, to manage the patient-related complications, the patient selection and pre-op evaluation is very, very important. We have to give enough information to patients about the possible results. We have to put drain. Also, we have to make appropriate plan for the surgery time, because the long surgical times can cause very severe problem, especially in comorbid cases. And also in deformity, we have to learn and we have to apply the spine biomechanic rules, and we have to follow the osteoporosis can cause devastating complications. So we have to know how we can manage the osteoporosis, and we have to use advanced strategies in case of deformity. And we have to learn previous surgeries, and we have to make our plan. Then we have to consider patient job for postoperative management. For example, if the patient needs the longer time sitting, of course, you have to burn. If they have to job in heavy works, so we have to burn again the patient to prevent some complications. Yeah, this is the postoperative period-related complications: hematoma, infection, valve problem, and early and overactivities also can cause some problems. Hematoma is very scary complications. We have some complications. We have some cases about this. I will show you now. If you even putting the drain, you can face with the hematoma. This is the case. You see, we did the operation, but in MRI, you see very, very severe complication. Then this is pre-op and post-op. You see post-operative MRI. And then we did the revision for removing the hematoma. This is another case. It was neurologically intact before the surgery. Then we did the two-level unilateral biportal endoscopic stabilization for this case. But after 24 hours, the patient neurological status was Asia B for lower extremities. Then when we take the MRI, then we see very, very severe hematoma. Then we did, this is the contrast. You see very severe hematoma. Then we did revision for removing the hematoma. And also during the surgery, we can cause the instabilities if you have excessive facet joint resection. You can cause instability, of course. Also, it is possible if you have a wrong portals, you can cause the base of sternobrochius fracture, and you can face with the wrong level surgery, and also you can do the incomplete surgery. So we have to protect the facet joint capsule especially. We have to choose correct portal points for this. And always it's double check your actual position during the surgery is important for preventing wrong level surgery. And we have to follow learning process strictly to prevent the incomplete surgery. Conclusion: endoscopic span surgery has many complications. Most of complications are preventable. Preoperative evaluation is important for reducing the complication rates. Following the learning steps is important to reduce the complications, and early management and intervention for complications can be helpful for preventing the constant problems. And I want to invite you again, our meeting. It is the Champions League of the world. Thank you for your patience. Dr. Pestonji?
My video. Okay. Am I unmuted? Can you hear me?
Are you here? Are you there?
The fantastic talk. It takes courage
Thank
to
you.
talk about one's complications.
Thank you.
You senior practitioners should come out with the honesty that you have expressed yourself with. This is an amazing talk, and I really appreciate your courage and your thoroughness in what you have spoken. Thank you very much. Now, Dr. Hayati, wonderful. I really have no questions for you. Dr. Hyeun Jinwa, are you with us? Dr. Hyeun Jinwa, are you with us?
Yes. Okay.
I have one question for you, sir.
Yes, sir.
Why not we change from TLIF to XTLIF permanently? Why do we have in our inventory, and why not we teach, and why not we keep XTLIF only? The reason why I'm asking you this question, Dr. Hyeun Jinwa, is because in my talk, which is going to be the next talk, you are going to see that in my journey in XTLIF, I have come across many cases of root adhesions, root entrapment, and these result in foot drops. These result in post-operative neural injuries if they are not taken care of. I personally feel that securing the exiting painful root, if the patient has a listhesis, and if the right leg is painful, I prefer to go and explore the entire right root. Therefore, I have now changed from TLIF to a complete XLIF in all cases. I have changed that, and this is my suggestion that I think for the coming generation of doctors who are going to join us in the journey in endoscopic TLIF, I think we should shift to XLIF completely. Because I have now made it a rule to check the root from axilla to outside the SAP. I make sure that every root I operate upon is completely in my visual field. It's completely.
Okay.
So this is my suggestion to you. I think we should cancel the category of TLIF and I'm for your opinion on that.
So this very nice suggestion, and your idea is very nice. I agree, totally agree with. But sometimes for freshmen and beginners, they not agree. Also, and in America, they are now developing expandable cage, maybe some business like that, okay? But still, I don't agree expandable cage.
Okay.
Yeah, big cage will be fine,
Yes.
but a little technical difficult, but we can get over that kind of limitation. Totally, I agree with you.
Thank you.
Okay. You're
I'll
welcome.
Talk. I'm just going to share my talk. There is my desktop here. Huh?
Okay.
There is my talk. Yeah. My talk is here, and I'm going to launch my talk. Can you guys see my talk, please?
Yes, yes.
Talk come on. So I'm going to start, and here we are. Now, I have developed a small variation in the process of doing T-leaf. I call it Dr. Malcolm's X-flavel T-leaf technique, and I follow certain new anatomical landmarks, which I've accidentally come across through the 100 I've done. And today I feel that I should share that with you all. So please bless me. We start with the standard targeting, standard portal. The working portal should be in line with the end plate so that, we can put in our cage, because basically UB is a one-handed surgery. It's not a two-handed surgery. One hand hold give you visualization. Your operative hand is just one. So therefore, this little change in thinking came across. Let me play this video, and you will see that I've already put in bone graft. I've created the end plates. But when I come out, you don't see any dura. I have retained the entire flavum. I go to the flaval separation zone with the upper lamina, but I don't open it. I put in my cage, and then I do the phlebotomy after having done all the bone work. Phlebotomy is the last 10 minutes of the surgery. Here you can see how slowly and nicely I'm opening up the flaval edge and then going upwards to expose the rest of the dura cord. So now what is the advantage? The advantage is I have 100% protection of the dura. I have no problems with the dura. I have not had a dural tear, a dural pull, a dural partial tear, arachnoid being seen. No, nothing like that. So with the extraflaval surgery, what I do is I remove the IAP and I just cut across the lamina until I reach the flaval separation zone, but I keep the flavum there. Even if I have to do contralateral decompression, contralateral opposite foraminal decompression, I do all that extraflavally only. It complements the rationale of UB being a one-handed surgery. You can see the pirate, that's me, with a sword in one hand, that is the operating instrument, but the hook is basically the scope. It identifies and secures the exiting nerve root, which is the most crucial element in surgery, and it causes pain. It provides a green corridor to identify the disc and placement of a cage without fearing or injuring a nerve root. But what is this it? Why am I saying it? Why am I keeping the it hidden? It has a detethering effect on the axilla, which is what I will show you and prove to you, and the exiting nerve root. But what is this it? So the it, we come to the story of the it. The it is the inferior communicating vein that accompanies the exiting nerve root. See, the human anatomy is fixed, but unfortunately or fortunately, we have never bothered to see this anatomy in detail. When we use a plasma, it has a penetration of only 0.5 mm. And in a low power coagulative mode, that is the blue mode, even that is not achieved. So I'm very safe when I can say that I'm caudal to this. This vein is caudal to the root by 2-3 millimeters, and I am caudal to it. When I chase this vein into the axilla, when I chase this vein across the traversing nerve root, and I chase it under the axilla, I am absolutely safe. It is like giving me a green corridor for an organ transplantation, where the police clears up the highway and the ambulances run at mad speed from one town to another to deliver a fresh organ. It's the same highway that I use, the same concept that I use in doing my XT lifts. Now, look at this anatomy here. When you see this anatomy, you will realize, and I will take you to the next slide immediately, because there I have marked it out. You can see beautifully the vein that is following the exiting route, the vein that follows the traversing route. It forms a triumvirate. How the Roman Empire was split between three people and there were three Caesars. Likewise, in this axilla over there are three major veins. These veins, they tether the root. See this anatomical diagram. Take your time to see it. What I can show you here is that I have cut the laminar bone right up to the flaval separation zone, superior pedicle, transverse process corner. I have osteotomized the SAP. I have kept the entire flaval tract intact. I can see inside the SAP, I can see its tip, I can see outside it. I can see it in 3 dimensions. Means floor. I can see the root accompanying the vein. I can see the vein accompanying the traversing route. Now, this is my heaven. This is my safe zone. When I'm there, I know nothing can go wrong now. However bad it be, however adherent it be, however tight 3 listhesis, this guides me. I'm showing you a video in which I'm chasing the nerve. I'm chasing the vein. So see how I'm chasing the vein and I'm going right up into the axilla. Nicely, I've removed the bony structures the way I've described. And now I'm at the superior pedicle transverse process corner. I'm opening up the axilla. I can even see the sliver of the traversing vein over there. So that was this video. See the next video. Same patient, I'm manipulating, I'm mobilizing the veins. You can see how that thick partially cut vein is there. You can even see an aberrant vein going downwards towards the traversing root vein. And now I must cut all these. But pay attention to the disc. As I cut this vein away, you can see as though the root is literally falling off that bulging disc and off that listhetic fold. And you can see how nicely the root is now floating, mobile, pulsating with the fluid column. So it causes a detethering effect. See this third stage of the video of the same patient. And you can see how beautifully we have prepared the end plates. Dura is not seen. The exiting route is from 3 o'clock to 6 o'clock, completely visualized. Cage is in. I'm turning the cage, making it horizontal. India is a poor country. Please forgive me. I use titanium cages. But I've used a large cage. And the next slide is what we have done. I have done a para-UB XT-lift. I went outside and did the XT-lift. See the cage, see the result. I think I'm quite satisfied with the reduction and positioning of everything. So this is what I'm trying to tell you, that once you are able to target and see these vessels, you can do anything. Sometimes when I open up the foramen, there is severe lipometrosis, massive amounts of fat, nothing can be seen. I'm scared. Where is the root? What do? I search for the vein. Gently, I can see the vein here. I can see the vein nicely over here. So a sweet baby sitting here. And now I can start using my plasma wand, turn it towards the cut SAP surface and push along it. Push up into the axilla, and you can see the triumvirate. You can see the 3 veins. The vein coming from below the axilla, the vein going with the traversing root, and the vein that is coming with the exiting nerve root. Cut it and see how the same kerosene, blunt, closed mouth, just pushing away, opened up the space, and now opening up the disc. So it is a persistent, consistent anatomy. You just need to look for it. Playing again this video, you can see how badly tethered and adherent this root is to the surface. Same 3 veins, same cutting the veins, securing the entire nerve root, right from axilla to outside the pedicle, going up through the axilla and pulling out an up-migrated disc fragment. This is what Dr. Pornpavit was talking about. I'm doing it routinely. But through UB, he's doing it through monoportal. 2 minds working in the same direction. See the next case. This patient came to me from elsewhere with 4 screws in her back, 20 years ago implanted. The top screws are not doing anything but just expanding the facet joints, removed them. The screw to the right appears to have caused fusion, but the screw to the left leg had severe pain and listhesis. So what do? I have to think of doing something. I have to think, how will I solve this problem? So I remove the top 2 screws. To hell with them, not my problem. I fracture the SAP. I strip it, and when I'm pulling it out, I can see how badly plastered and adherent this root is. If you're not careful, you don't gently strip this, you can have nerve root damage. This is exactly what I was talking about, Dr. Yumjinwa, that we need to shift to XT-LIF in all cases. And here you can see the 3 veins at the bottom. You can see how nicely I'm going to now push open, expand open my thing. My root is to my side. I've secured it. I'm confident I'm coming out of the SAP. Now my surgery is going to bring me success. And believe me, it was a wonderful success. So keeping these veins, keeping this corridor, can you see how badly untethered that root is? It is still not giving way. I had to struggle, and I did struggle to push it away, strip it away, open up the whole corridor, and get to the bottom of and onto the discal surface. So I prefer to use these veins. You can see the vein with the traversing root too. Here you can see that I opened up a small sliver or a corner of the traversing root. So this is the result. And in this case, since the other facet was fused, I did not remove that screw, accepted it, did only a unilateral fixation, which is actually a bilateral fixation. This is again a case where I'm not able to get below the SAP. I'm not able to cut around the SAP. What you can see here is a complete superior articular process. The IAP is gone. The dura is in front. I'm trying to come round the SAP, and I'm not able to. I'm not able to push in there. I'm scared. Is there some nerve root trapped there? Will I injure the nerve root like in the previous video? So, but I see the 3 veins. Now, the moment I see the 3 veins, you can see the 3 veins here. I decide now I can do an osteotomy. I gently do an osteotomy of the SAP overhanging part, push it away, and you can see the discal surface nicely and beautifully below it. So this is the anatomy that I'm talking about. This is the anatomy that has been there for ages, but we have been missing it. And once you cut it, you can see how beautifully the root has shifted away. I've gone below the root. I've moved it out of my working zone. I can nicely prepare an XT-LIF corridor. So this is again a super extreme case of lipomatosis. Again, a degenerative lytic listhesis. And see over here, you can see the vein. And once I see that vein, I know I cannot hit anything. I can see both the veins. Let me just burn everything in between. Let me take care of it. It all disappears by using the plasma wand. It is my safe space. There is not much of collapse in this case. In the previous case, there was a lot of collapse. The triumvirate was very close to the lower pedicle. Now it's away from the lower pedicle. You can see some aberrant veins over there. They are not the primary veins. We're going to tear them out. That up there is a primary vein accompanying the root. There is a primary vein accompanying this root. Tearing it all open and then preparing my grounds for putting in a cage. So the same anatomy, just reclassified, reworked upon, rethought about. But in difficult cases, it's like a beacon of light. Work towards the SAP, find the tri-junction, and then move upwards. Especially in collapsed grade 2, grade 3 listhesis, makes your life very, very easy. So what is my take-home message? What may be trivial to an open spine surgeon, he may not even think about it. He just sees bleeding there and he burns it and packs it. For me, it's a lifeline. It's a beacon of hope in a very tight spot. UB is basically a one-handed surgery as such and has very different demands than compared to other types of spine surgery. So I will not compare to monoportal. I will not compare to transforaminal. But I feel that UB gives me complete control over the root. It makes sure that if there is anything there, any associated pathologies, I can take care of them very beautifully. It offers unmatched safety in difficult cases because the root is in my control. I can see my cage going beyond it beautifully, not even touching it. So these new anatomical considerations are a must for an UB surgeon to understand and acquire and search for in his journey. I hope you have enjoyed this talk. So I shall stop my share here. Dr. Anand, I see you online. Can you unmute yourself? And I'm open to receiving any questions, but I think we will take the questions after Anand's talk. So Anand, can you please share your screen and can we get on with our program?
Yes. First of all, good evening to everybody and season's greetings to all my esteemed friends and the world-class endoscopic surgeons which we have here on the board today.
You're praising me for no rhyme or reason.
Okay, can you see the screen now?
Yeah, we can see you, sir.
Okay, so I will be speaking on philosophy of lumbar foraminal and the present state of transforaminal endoscopy and the advances what we are doing in our regular practice. So friends, we all know that the traditional spine surgery for a degenerative spine involves tackling the disc surgery and stenosis decompression surgeries. And the conventional way to tackle this was large exposures, cutting out the spinous processes, the muscles were elevated and stripped off, the lamina was cut, the facet was cut. So basically, it was a challenging approach for a very small pathology in the depth, and we had to go through several layers, and particularly difficult in obese and comorbid patients. Now, if you see the literature, most studies show you that post-decompression, there was decreased leg pain in nearly 70% of the cases, but it was not the case with the back pain. And why this was due to the collateral damage of the surgery. Now, what is the final goal in case of these pathologies? It is the decompression of the nerve, and which has to be very safe and precise. Now, this collateral damage, which was caused due to the invasiveness of our procedure, increased the post-operative morbidity. Now, with this understanding, operating microscope was introduced and microsurgical techniques were developed, various instruments and retractors were developed. And what were the lessons learned? Microsurgery decreases the collateral damage. But yes, it required discipline, it required preoperative planning, it required access strategy, it required respecting the anatomical pathways. Now, simultaneously, tube systems and mini speculum approaches were developed to reach the spinal canal. And essentially, three approaches were explored: the interlaminar approach, the translaminar approach, and the foraminal approach. Endoscopic techniques were being developed parallelly. And with the introduction of the percutaneous nuclear extraction method by Dr. Hijikata, the transforaminal endoscopy evolution started. Later on, Dr. Pervez Kambian defined the safe triangle, and Dr. Anthony Young described his inside-out technique for the transforaminal approach. Simultaneously, the interlaminar techniques were also evolved and developed. The UBE was developed. But now let's see what, by definition, we mean of minimally invasive surgery. It means that doing only what is necessary and dealing with the pathology without disturbing the normal anatomy and physiology. What is minimal access surgery? It is accessing the pathology with minimal destruction of the intermediate normal tissues. And what is natural orifice surgery? It is utilizing the natural orifices and windows in the body to access the pathology. Now, lower down here, we see three representative diagrams of various techniques, and you can very well appreciate that the transforaminal endoscopy has the least mark and it's the least invasive. So let us see, I will showcase some of the different indications where we use these transforaminal endoscopy successfully. Coming to the down-migrated herniation. Now, even in case of an extremely down-migrated herniation, transforaminal endoscopy is a very safe and easy approach. First of all, because we do it under local anesthesia. We dock our endoscope just below the pedicle, we identify the bone, and with a burr, we just create a small window. Now herein we are not disturbing the discal anatomy because disc is part of the 3-joint complex and we do not want to disturb it. We only want to tackle the herniation. So with a blunt hook, we can just manipulate and bring the herniated fragment in our field and grab it under the endoscopic vision. And this is the free dural sac in the lateral recess, which is very well seen through the bony window which we created. And mind you, this is absolutely a stitchless surgery, so there is no collateral damage. Next case. Now, in case of up-migrated herniations, usually they migrate up in the hidden zone between the two roots because that's the path of least resistance. And to approach this area, we need to cut a lot of bone if we approach it through the interlaminar or, mind you, even the paraspinal approach, because we need to tackle the pars bone. Whereas in case of transforaminal endoscopy, it's very easy. You just identify the exiting route. You just identify the Malcolm's described vein, and then you can just go inside and cut that tissue anchor, which is anchoring that up-migrated herniation there. And through this window, now you can put your blunt hook to tease that up-migrated fragment in your field. So while you are doing it, you can also cross-check in your C-arm that where exactly is your lie, and slowly tease out the complete up-migrated fragment and bring it in your endoscopic field. Once that is done, it is very easy. You just need to grab the base of the fragment and get it out. So even the operative time in these cases is reduced drastically. There is no soft tissue clearance. There is no excessive use of RF. There is no excessive bone cutting, no drilling. And herein we can see the free traversing route and the exiting route, and the up-migrated fragment is out. Let's go to the next indication, discogenic quadra equina. Now herein, the pressure on the dural tube is through the anterior side, and putting a big footplate instrument from the posterior aspect can further jeopardize the already compressed nerve roots. Whereas transforaminal approach affords you a very safe approach, and you can just go underneath the annulus through which the disc fragment has mushroomed out, create a small nick, and again use a blunt probe to just tease the fragment inside your endoscopic channel. And without hurting the roots or the dural tube, you can get the entire herniation out and you can visualize the decompressed sac. Next indication, extraforaminal herniation. Now, extraforaminal herniations are extremely painful and they are very difficult to tackle, particularly in old patients with multiple comorbidities, bad patients for anesthesia. Transforaminal endoscopy is very easy way to tackle this. Just put the endoscope, identify the root, and just tease off that extraforaminal fragment. And grab it out. Everything is done under local anesthesia and minimal sedation. And this is the free exiting route, very well decompressed. This is the postoperative MRI, recreation of the foramen, and this is the happy patient. The surgery is very gratifying. Coming to the stenosis. Now herein you can see there is lateral recess stenosis due to an anterior osteophyte. So tackling this from the posterior aspect is very difficult, whereas here under local anesthesia, without damaging the collateral tissues, we can directly enter the foramen, land on that bony excrescence, break it and bring it out piecemeal. And with further soft tissue decompression, you can very well see the decompressed dural tube there, the axilla, as well as the exiting root. So no paraspinal muscle stripping, no burring. Another case of a foraminal stenosis, severe foraminal stenosis around the tip of the superior articular process. So under local anesthesia, again, you can do it through the foraminoscopy. A simple slow burr can be used to undercut the tip of the superior articular process. So actually, this is the same thing what we do in a paraspinal approach, but through a different angle. So once you clear off the tissues, the lateral expanse of the ligament flavum, you can very well access the lateral recess. And your roots are completely free. So this is some RF being used to shrink the axillary tissue. And the entire foramen is now very well decompressed. This is the exiting root. And as we turn the cannula and the endoscope, we can see the lateral recess decompressed and a nice traversing root and the lateral edge of the dura. This is the post-operative MRI showing the free nerve there in the foramen and the lateral recess decompression. The same technique can be used for putting a transcambin cage and doing a facet preserving surgery. All these images are courtesy Dr. Malcolm Pestonji, who has mastered this technique. So basically, advantages: superior visualization of pathoanatomy. It's the least invasive. It's possible even in unfit and difficult patients. Simple post-operative management, and complications are minimal. And even if they occur, they are very easy to rectify. Drawbacks: yes, as already mentioned before, it definitely has a longer learning curve, and there are less training facilities presently for transforaminal surgery. And then there is investment into the costly instruments. So friends, thank you very much for your patient listening. And thank you once again. Hope you have liked it. Malcolm can't hear you. You need to unmute yourself.
Thank you very much, Anand. Exclusive talk by an exclusive transforaminal surgeon. Genius in this world. I really appreciate you, Anand. You make difficult surgeries seem so easy.
Thank you. Thank you so much.
Up to you. And I think there's a new generation of upcoming transforaminal surgeons whom have a lot to learn from you. So I would like to now conclude our talk, and I'm just waiting for a vote of thanks from Dr. Vishal Kundani. Are you with us, Dr. Vishal? Hello. Dr. Vishal Kundani, are you with us? I think he must be busy in the OT or something. So I want to say a personal thank you to all the speakers who have removed their precious time, effort to put across such beautiful views to the world today. So once a big thank you from Ortho TV, ASICON, World Federation of Spine Endoscopy, and to all the speakers and to Dr. Sameh for having removed time for us. Thank you very much. Thank you once again. Bye-bye. I think we can leave our meeting. Just 1 second. There's some 2 chats, so let's see what it is. Why did retinal bleeding occur was one of the questions that has been asked to us. Yes, when you have severely raised intracranial pressure because of epidural pressure rising and because of the patient having a head down position. That is why Dr. Hayati mentioned something that when I do my surgeries, I keep the head up by 10 to 20 degrees. This is an auto correction that you achieve. Otherwise, when a patient is on a Wilson's frame and you have broken the frame to try and get lordotic correction and to get a flat back, the head is lower than the back. If the surgery is over a long period of time, you can have punctate bleeding in the retina. So better is at such times to please keep a correction to be done. So that is the one question that was asked, and I don't know whether there's any other question now. There are 2 new messages, so let's have a look at them. Dr. Balgopal, thank you so much for having been with us. Thank you so much. I think we can conclude safely now. Thank you so much, everybody, once again. Thank you. Good day. And I formally close this meeting. Thank you so much.